60-year-old male, came to us. He was a known diabetic since 25 years. Right eye, he had undergone vitrectomy elsewhere a few months ago and did not regain very good vision in that eye. He primarily came for opinion and management of that eye with defective vision. His left eye, he was quite happy, 6/24, but he had good reading vision innate and he had stable PDR post laser in the left eye. And the right eye had recurrent detachment under silicone oil post vitrectomy due to PDR. And we did a revision vitrectomy, we did membrane peeling and injected oil. Though the retina remained flat, the vision was quite poor. And patient continued to follow up with us regularly for periodic examination. Kept coming and the left eye was normal. He was managing very well. Almost 2 years down the line, September 2012, then he came with blurring of vision in the left eye. Left eye was always asymptomatic till now. Vision was still 6/24 distance, but the near vision had dropped to N12. Cornea was clear, both eyes were pseudophakic, right eye had silicone oil, left eye intraocular pressures were normal. Can you brighten this? I'm sorry, originally the quality itself is poor. Right eye had flat retina under silicone oil with a pale disc. You see the reflexes you see are from the silicone oil. Left eye had a stable PDR post laser. You see a large area of proliferation which had become gliotic. And this was a thickened hyaloid phase which had totally detached from the retina. And it was free from the macula, and the underlying macula looked normal. And in fact, we had done OCTs earlier for left eye, it was normal. So this patient presented with blurring of vision in the left eye. We thought, okay, it must have progressed to macular traction. But when we did the macula OCT, it was totally normal. There was no traction, no edema. It was not at all different from the previous OCTs. And this shadow here is mainly because of that thickened hyaloid phase which had cast a shadow on that he had had for a long time. It was nothing new. So there was nothing to indicate why this patient had decreased vision. So in summary, we had a patient who had a stable PDR post laser in his left eye. It was good eye. And he came with a recent drop in the vision, mainly in the reading vision. Pseudophakic patient, macula was looking normal, there was no macular edema, it was flat on OCT. So we could not really think of a cause for decreased vision. We looked at his systemic factors, we did his refraction, we kept on following him up for 2 weeks, 1 month, and then he came back after 1 month, his vision was same, he said still blurred. We also could not really decipher what was happening, but at one point of time we had done OCT of the disc. This was the OCT of the disc in September, and we did notice that there was some gliotic proliferation causing some elevation of the disc tissues, but we did not pay much attention to that at that time. But when the patient persistently had decreased vision, that is to draw your attention to the gliotic proliferation causing traction on the disc. So when patient continued to have blurring of vision and we could not identify any cause, then we looked at serial OCTs. That was in September and May. We could see that the traction had increased gradually over the 5 to 6 month period that the patient was being followed up with us. And by May, his vision had dropped to 6/36. Even the distance vision had dropped. So this is when we came to the diagnosis. Can anybody give the diagnosis here? Well, to sum up, we have a patient who had a stable PDR post-laser, macular status is stable, no edema, no traction. Patient is symptomatic, very symptomatic, and gradual decrease in vision. The vision is dropping and we are unable to find the cause. There is a gliotic tissue causing traction on the disc. OCT shows a clear-cut elevation of the disc tissue and the traction by the gliotic tissue. And serial OCTs during the follow-up also shows increase in the traction. And that's when we made the diagnosis of avitrio papillary traction. And at this point of time, we did advise the patient to undergo surgery. But patient had undergone already 2 surgeries in his right eye, and his outcome was not good. So he was naturally very reluctant to undergo surgery in his left eye when he kept on asking us, can you guarantee me that the present vision will not go down? And I would like to take you back to the fundus picture, what was there. I think if you look at the fundus picture, that was the patient with PDR, and you see this large gliotic proliferation which was there. And we could never categorically say that yes, you can undergo surgery, there is absolutely no danger of losing the vision. We kept telling there is a small risk that vision may go down if things don't work out, if we're not able to dissect the membranes, if the retinal breaks develop, you may have a problem. So patient did not make up his mind for surgery for several months, and ultimately after about another 3-4 months of repeated visiting, counseling, talking, ultimately patient decided, okay, I will take the risk, I will undergo surgery. To circumcise the membranes causing traction on the disc. And we did inject silicone oil because I think being a one-eyed patient, and there was one break in the superior retina away from the posterior fold, but being a one-eyed patient, we wanted him to have vision, in the immediate post-operative period also. And therefore we injected silicone oil, and post-operatively the patient had good vision with silicone oil, and silicone oil was removed in January 2014. Subsequent to this, he has had 2 follow-ups, and patient is very, very happy. Patient has regained a vision of 6/18 N6, and this is the disc picture of the disc following surgery. We are able to remove the membranes completely, and this is the OCT of the same patient following surgery. So with this, I would like to just present another 3-4 cases of similar variety, and maybe we can have some discussion on this topic. 61-year-old male, again drop in vision, recent drop in vision from 612 to 624 patient, presented to us with PDR. He had undergone laser, he maintained reasonably good vision, but you see how there has been extramacular traction, and this is the presentation. Macula is flat. There is no macular traction. There is no threatened macular detachment also. But look at the disc. And going from our experience with the previous cases and our awareness about this condition, we made a diagnosis of vitreopapillary traction. Patient underwent vitrectomy, and this was the pre and the post-op picture, and this is the OCT of the same patient. We can say patient regained 6/12 vision. Another example of a gliotic proliferation on the disc causing traction with a decrease in vision to 6/60. Following vitrectomy, we have relieved the traction. You can see the OCT picture. One important tip I would like to give you when you are trying to do something like this, in a case like this where there is a traction, we do not really pull the proliferation of the disc. I don't think that is recommended. We don't know how strong adhesions are there between this gliotic proliferation and the disc tissues and whatever tissues are there at the disc. Our aim is to remove the vitreous hyaloid phase and circumcise the tissue on the disc, like what we have done here, so that the tractional component, what you see here, this antero-posterior traction, is relieved, and that's our aim when we do surgery here. We never pull it off like what we do in an ordinary case of a PVD induction. So please keep that in mind in case you ever happen to do surgery for something like this. And another case with proliferation, traction, some nasal dragging, and we repeat here also the vision improved to 6/18. And all of them, let me emphasize here that we did see the patients for at least 1 month or even 2 months before we arrived at the diagnosis. We followed up the patient when we were sure that vision was not improving, it was gradually dropping, and then we made the diagnosis and we discussed the surgery for the patient. These are the OCT pictures of the 4 patients, and that is just a schematic to show how the traction on these axonal fibers, the ganglion, the fibers of the ganglion cells, could cause decreased vision by this tractional forces. And so in conclusion, I've just presented a series of cases where vitreocapillary traction was diagnosed as a cause of decreased vision. All of these were patients with stable PDR post-laser. The clinical features from OCT of the disc can help us to diagnose VPT when we rule out all other causes of, I think it's a diagnosis of exclusion, I would say. And once you are sure that it is the tractional component on the disc that is causing the problem, vitrectomy should be considered. And till date, we have done vitrectomy for about 7 cases out of 10 that we have seen in the last 1.5 to 2 years. Thank you.